Thank you all for coming to the workshop this morning. I'll just give a very brief overview of some of the gaps in care that I talked about in the keynote just now, in case anyone wasn't there, and then love to hear some introductions from you guys, and then we'll have 3 breakout sessions that will put people into small rooms to have some discussions, then report back out to the group. I started my other presentation with this, but stigma is a big thing for me. And there's a lot behind the way we talk about substance use disorders, but would love for us to think about using the medically accurate person-first terminology as opposed to some of the outdated stigmatizing terms. As we think about, the gaps in care and what we can do to work on them, I like to keep in mind the levels of prevention, primary, secondary, and tertiary. And also thinking about the cascade of care as youth kind of transition between different stages in their treatment and recovery, and what are the places that they may be vulnerable and falling off of this pathway. And thinking about all types of interventions, whether they're, small focus on the individual or much larger scale policy interventions. And then the continuum of care, going from some of the early intervention work that starts in the pediatrician's office, in the schools, and after school programs, things like that, outpatient services, all the way up to more intensive inpatient and residential services for youth, and how and whether these are available in the areas that you all work and live, and how accessible they are. And then I shared work from my study that was published in JAMA Pediatrics looking at receipt of addiction treatment after overdose among youth. And in brief, less than a third of youth who have an opioid overdose receive any sort of timely addiction treatment after overdose, and only 1 in 54 receive the evidence-based medications, which is far fewer than adults receive after an overdose. And then I shared from another study where I looked at the availability of adolescent serving addiction treatment facilities in the United States, and found that there are very few facilities basically that treat adolescents, and even fewer that actually provide medication for opioid use disorder, and could explain part of that gap between why youth are less likely to receive medication. For this, would love to hear, this is, I think this will make a word cloud. So what do you think are the most problematic gaps in care for youth with substance use disorder? So this will be, you guys can go to slido.com and then enter some of the gaps, and we'll see. So intervention, reliance on insight and voluntariness. I think that's a big one for youth. Lack of trauma support. Full spectrum of services. You have all the different levels. Housing. Yeah, I think we often sometimes think about just the medical aspect. So I'm really glad that we have so many healthcare providers here as well to think about all those other aspects of life. Because when you think about the hierarchy of needs, like housing and food are higher than medical care. So we really need to think about that. Full spectrum of services, concurrent disorders. I think based on the size of this, a lot of people are agreeing with the full spectrum of services. Complexity of navigating the system, I think that's a big one. We heard in the opening remarks this morning, people talking about how it's easier to buy drugs than it is to find treatment. And I think families and patients really struggle. Lack of education and knowledge. Consideration of culture and care, I think that's also a big one. That's a really good point. System overload, historical trauma inflicted by healthcare on people. I think that's huge. And we certainly deal with that a lot where I work right now. Hopkins has a difficult history with some of the people of Baltimore and harms that have been done to them by the institution. Integrated services, lack of permanency, marginalization of substance use disorders and medical treatment. I agree. I think it's not considered part, it's not the same as cardiology or OBGYN, something like that. And even insurance, I think that continues to worsen that. It's often a carve out, at least in the US, that's how it works. It's not the main insurance provider that provides it. Well, this is awesome. So I think we have a lot to discuss, it looks like. So I'll move forward towards the breakouts. That way we can have a little bit more discussion. So I wanted to first have our first small group talking about stigma. So we'll give you about 5 minutes. And if you want to introduce yourselves to your group and give an example of stigma that you've witnessed related to youth addiction. And I think, and you could think about the ways that this can lead to gaps in care, whether that's stigma against treatment, stigma regarding medications not being good, the whole abstinence only versus medication assisted. We often see that with like AA and NA, labels that people use or other things. And then, things to combat stigma, what you personally have done, other things you've read about. And then we'll have a few minutes to report back to the group as well. So, all right, it looks like folks are coming back. So would love to hear from a couple groups about what you guys discussed, if anyone wants to share some of the conversations you had.
I'm happy to give a comment if that's helpful. So youth are so connected to the school system. So I'm working in Southwestern Ontario, and our school boards are often so focused on academic issues that they are very reluctant to be very engaged in providing both good substance-related information, because that's kind of taboo. You don't want to think of your grade 6 student as using opioids. And so trying to get appropriate information into schools in a way that could be that early intervention, prevention type of information, and to try and target the kids who, when I say target, that's a terrible word, to try and reach out to the kids who we know are in trouble, because we look back, you can see who that is very often. But to actually do that in a way that is kind and supportive and includes family and doesn't stigmatize and make things worse is something we haven't done. So there's just a ton of opportunity for us all to do it better.
Yeah, thank you. I love those points. I think that's so important. I think the fact that it's taboo is a huge part of stigma. And I wonder if there's stuff that we can learn from some of sexual education and how that's evolved from people not talking about it to abstinence only to trying to do more comprehensive sex ed. But thank you for sharing that.
We were in our group in 10, we were just discussing all the different areas of stigma. So like looking at the huge piece of racial discrimination and disparities and inability to access Wi-Fi and transportation and all those kinds of things. And then I think in terms of even when you're looking at that taboo per se, it's a lot of times in my experiences working with youth, there's a lot of trauma going on. So when I work with downtown or family and children's services, and there are very few people, especially in some of the areas where it's highly needed, there are very few people that can provide trauma support. So when it comes to addictions, which are very highly correlated for youth, they kind of look at just the trauma or just the addictions, and they don't know what to do with the trauma, so they don't address it and they pass it along. And then that just feeds the stigma that it's never going to be addressed and there's not, don't talk about it and that kind of thing. I think it just facilitates that correlation, the stigma of historical trauma, immediate trauma. We were talking about the difference in women and youth disproportionately being affected that way too.
Yeah, I think those are all super important points. And I think that also leads into some of the police and incarceration issues that and the disparities associated with that, a lot of what you're talking about. And I think one of the reasons that some of the multidisciplinary conversations are so important, because you can focus on your one narrow issue, but it's a whole person with a lot of different things. So thank you.
I think too, just building on that, sorry, is I live, I imagine this happens everywhere, but when it comes to, I work with youth and young adults with substance use and mental health. And we often come across, well, they need to deal with the substance use first before accessing mental health services, or they need to deal with their mental health issues first before accessing substance use services. And we, as we all know, they're very intertwined and interwoven. They're concurrent. So we deal with quite a bit of, accessing service barriers when it comes to those type of issues.
Yeah. And ideally we can work on them both at the same time and not worry about which came first, but just they're both there now, address them both.
And I agree with you, Jen. I think that stigma has been around for a very long time. I work predominantly with adults with addiction, but I think that some of the issues, the barriers are similar. I feel that, it's sort of at the heart of my practice is connecting. And sometimes, people in the system, we're busy, we're running around and we don't have the time to make the connections, to establish that connection. And I feel it's particularly important with adolescents. If you can't develop that connection or establish that rapport, it's really hard to make inroads. And things like, barriers, things like not enough staff that aren't educated, lack of housing, that's huge. And I feel right now that there are a dual pandemic, the opioid crisis, as well as the COVID, but also the housing crisis. That is a crisis. And as it relates to Maslow's hierarchy, it's really difficult to, suggest that somebody, adult or youth, stop using substances when they don't have a safe place to be. I'd be using substances quite a bit. And I also think too, like medications, there's lack of education. Youth are reluctant to take medications anyway. The irony is that they'll go and use drugs illicitly. But when it comes down to sort of a prescribed medication, it's like, hang on here, So just education and more discussion, ongoing discussion, I think will be helpful to break down some of the stigma.
Thank you. I feel like that was a lot of really good points. I think the heart of it comes down to just that connection and building rapport and making people feel cared about. And I lead our resident education for the pediatric residents and talk about how even if you're not going to get them to change, like focus on building that relationship so that they know that you're a safe person to come back and talk to about it, and that you're trusted, and then you can go from there. But nothing else can happen if you don't have that level of trust and think about all the other aspects of life like housing. So yeah, really a lot of really important stuff there. Awesome. Any other groups want to share, or should we move on to the next breakout?
I'll share one thought. I think our group, we touched on a lot of the topics that were just discussed, and I had the pleasure of having 2 child protection workers in my group, and then I'm a regional level health administrator. So I'm looking at it from a very different lens and perhaps a 30,000 foot view rather than more frontline, and where I don't have, the honor of engaging directly with our clients. But one of the things that I see, it was touched on a little earlier with the silos in care. So treating mental health and then substance use as if they're not concurrent. That's a barrier. And then I wonder as well about the stigma within our own physician communities, especially amongst psychiatrists, about addictions medicine and sort of whose job it is to deliver safe care, and sort of bridging that gap between addictions medicine specialists and psychiatry as well.
Yeah, I think that's awesome. I think we need more very multidisciplinary conferences like this. I think I tend to go to the medical ones that have a lot of people that think a lot like me, but I think conversations with lots of different types of people in different fields will help break down those silos. So that's awesome. Cool. Well, glad you guys all had some productive discussions. So the next thing to just, Okay, so we're going to talk about levels of care. So if you guys can go back to the Slido, want to see what you think. What levels of care are not sufficient right now where you work and live? I feel like where I work, it would honestly be a lot of these things, but I'd love to see what you guys think too. And then I have a couple questions. I guess we can send that out through the breakout. here, let me go to that while people are answering your Slido. So for the levels of care, just to talk a little bit about what levels of care are available to the youth where you live and work, what's missing, what is the balance like? Is there a lot of low intensity but not enough high intensity? Is it all focused on medical treatment and not psychosocial? What sort of geographical disparities exist? And, where should efforts be focused if you're going to think about. Cool. So while people come back, I just brought up that Slido poll again. And it looks like not everyone, what percent? 80% of people are saying that prevention and early intervention services are not sufficient right now. And then about 60% saying outpatient services, residential, intensive outpatient. So it kind of seems like the best level of care that we do have access to is maybe that outpatient medical services, and we need more on that prevention side. Cool. Again, helpful to have multidisciplinary people. In my head, I tend to think about the medical side of things. So thank you guys. So let me go back to the slide prompts. So if anyone wants to share what you guys talked about in your groups in terms of what levels of care you have, what the balance is like, geographic disparities, or where we should focus efforts to improve, I'd love to hear what people have to say.
I'll go ahead. What I heard from my group, we had 4 of us from British Columbia and 1 from Ontario. I'm sensing a real challenge and shortage of resources and services in remote and rural communities, which I've seen in our jurisdiction here. And then, of course, more intensive levels of care where the ratio of provider to client is tighter. We're not able to get necessarily that level of service for folks that have a more intensive level of care needs, especially in the remote communities, but in bigger cities as well.
Has any of that changed with COVID, at least where I am, with some of the services being virtual, although it may not be as good? More people sometimes are able to access them because you can be wherever. Have you seen that that's expanded treatment for some of the youth that live out in rural communities?
Yeah, it certainly has. I think it's decreased the barrier to receiving some of the kind of lower part of the pyramid levels of care and for that sort of segment of the population. But I can't say that it's gotten any easier for people requiring tertiary levels of care, more intensive needs of care, kind of at the tip of the pyramid.
Yeah. Any other groups chat about maybe some of like the geographical disparities or how that's changed with COVID? Has anyone seen different patterns other than rural areas having worse access?
I think from an urban perspective, COVID has put some things that were sitting on the back burner, have moved them forward, certainly harm reduction strategies. And that's what I see has kind of maybe improved, is that, people are out doing a lot more outreach to, support vulnerable, populations. Certainly if they're unwell with COVID, that kind of thing. So, and, some of the harm reduction strategies that we've been working on for months and months and months and months, seem to, become operational with COVID. So that was a positive thing.
Okay. Helpful to hear. What about that balance that other people talked about potentially between some of the low intensity and more higher level of treatment, or where we should be focusing efforts? We've heard that it seems like everyone kind of thinks there isn't enough of that early intervention from that poll, but yet we're also talking about how it's really hard to get that higher level. Any other groups chat about that?
I always can have some input. The irony, and again, I'm not as well versed on the services that are available for youth. When you say higher level, high intensity, certainly on Vancouver Island, I'm not sure that there is in relation to substance use treatment, that higher level of care exists.
Mm.
Certainly to meet the needs that we're speaking of, you know, youth responding, or us responding to youth that are having overdoses, et cetera, et cetera. So
Okay.
I
Yeah.
think our focus needs to be on building the services.
Yeah. Well, it looks like we have a couple minutes left. So how about we'll have a brief, or like a 3-minute group discussion where we talk about transitions between levels of care. So would love to hear what you guys think. Maybe kind of focusing on what are the gaps where the transition isn't smooth and youth can be lost. Whether you're thinking from youth that are going from a high intensity, like a residential services, back out into the community, or someone that's struggling with outpatient treatment or in school. So what are the most vulnerable transition points for these youth? And have you guys seen any good examples of like seamless transitions? So we'll do like a quick 3-minute brief chat and then come back together to wrap up. All right, so I think we have people coming back. We have time for maybe like 1 or 2 groups to briefly share thoughts that you guys have about that transitions and where people are vulnerable.
A huge one everybody is talking about is aging out. So that transition between under 18 and over 18. I know I have students and it's their psychiatrists and their supports, all of a sudden they don't have them and they're on a wait list for adult versions. Or if they're in family and children's services, all of a sudden they don't have that contact anymore. So
Yeah, that's a huge one.
I think going back as well to that connection piece and having to, once they do age out, having to create new connections with new resources and new workers, as well as an extreme barrier for a lot of youth.
Yeah.
I personally think that we should be working collaboratively with youth until they're 25. Say that their brains aren't fully developed until that time, but yet, we're sort of putting them into an adult system that is already taxed. So
Really. In our clinic, as adolescent medicine, I have the pleasure of seeing people from like age 12 to their 26th birthday. So it's nice that we can help them through those transitions. If only everything else worked that way, so that we could help teach them how to navigate and learn all the life skills that you need to during that time period. But maybe more linkage between the services for youth and then learning how to navigate the adult stuff.
I find even the transitions, like in at least where we are in British Columbia, there's like 3 ministries involved with childcare for mental health and substance use, right? You got the Ministry of Health, MCFD, and the Ministry of Mental Health and Substance Use. That's a lot of large systems that need to talk to each other, right? And so if you're starting with those like complexities at the top, how is that not going to be difficult at the bottom, right?
Yeah, difficult for us to navigate, let alone a youth that is, 18 and struggling with an addiction. Cool. Well, thank you guys for participating. I think it's about time now to head back to the main session, but really, I found it really helpful to hear from all of you guys, your ideas, and look forward to continued conversations during the workshop, and feel free to reach out to me if, want to have any further discussions, but really appreciate everyone's participation today.